Hello and welcome to the Sentinel Innovation Center webinar. I'm Leslie Curtis from the Duke University School of Medicine, and I'll be moderating today's session. The U.S. Food and Drug Administration Sentinel System helps to address questions related to the safety and effectiveness of marketed medical products. The Sentinel Innovation Center focuses on developing innovative methods to further advance Sentinel by using new data sources, building new tools, and enhancing real-world evidence capabilities through advanced analytics. We launched the webinar series to engage experts and innovators in key areas related to the Innovation Center's master plan. And with that, I'm very pleased to introduce today's speaker, Dr. John Duke. Dr. Duke is Director of the Center for Health Analytics and Informatics at the Georgia Tech Research Institute and a Principal Research Scientist in the Georgia Tech College of Computing. His research focuses on advancing techniques for integrating, analyzing, and communicating complex health data with applications that span safety, quality, public health, and clinical domains. Dr. Duke was a founding member of the Observational Health Data Sciences and Informatics, or Odyssey Consortium, an open source international health data analytics collaborative. The title of Dr. Duke's presentation today is Portability and Scalability of Computable Phenotypes, Trade-offs and New Trajectories. Now, before we get started, just want to mention that your lines are muted. So if you'd like to pose a question, please type it into the Zoom Q&A feature. I'll be moderating that, keeping an eye on it, and then we'll aim to answer as many questions as we can at the end of the session. As you may have heard at the beginning, this session is being recorded and will be made available through the Sentinel webpage, which can be found at sentinelinitiative.org. So without further delay, John, thank you so much for joining us, and let me turn it over to you.
Well, thank you very much for the kind introduction, and thank you for inviting me to join today in the Sentinel Innovation webinar series. As mentioned, I'm going to be talking about phenotypes with a particular emphasis around portability and scalability. A lot has actually happened even over the past 1 to 2 years in this area, and I look forward to the discussion with all of you today. Just to note, while I don't have any personal financial conflicts of interest, our research center at Georgia Tech does get funding from organizations including FDA and CDC that conduct work related to the topics that we'll be discussing in today's webinar. So the broad overview of today's discussion is around phenotypes. And just as a core and axiomatic point is that the construction of phenotypes is really a cornerstone activity in health data analytics, whether they're used for research or quality, safety, cost, or clinical objectives. We're going to focus around aspects of phenotype portability and scalability, with particular emphasis on recent policy, standards, and tools that can inform phenotyping decisions related to these dimensions. One of the key goals around this presentation and thinking about this area together is to enable broader use of electronic health data beyond current commonly used data sources. So I'll begin recognizing that many of you have a great deal of experience in this area of phenotyping, but others may have not either worked in the domain or may be sort of curious how others think about the topic. In my mind, a phenotype is a logical definition of a clinical event or state or a characteristic of interest. And that computable indicates that the phenotype is machine interpretable in some way, so that it forms a query that can be run on a data source to find patients that match a particular definition. So to provide a little bit more of a concrete sense, in safety contexts, phenotypes will often define exposures, such as patients who received a given drug, or outcomes, patients who had a given condition, an outcome such as myocardial infarction. So the phenotype notion is clear, but what do I mean by portability and scalability? And in my mind, portability refers to the performance of a phenotype in generating consistent cohorts across diverse sites. In other words, did you find the patients that you're looking for? If you run a phenotype that you've created and you run it at one site and you run it at another site, there should be consistency. And so it reflects the design of the phenotype content and logic. Where scalability, to me, refers to the ability for a phenotype to be actually run on a wide range of sites and data sources. And in that regard, reflects the infrastructure and platform and adoption and so forth around the running of the phenotype. So these two closely related elements reflect in some ways different aspects. Both of them are important, but are sort of looked at through different lenses, both sort of a scientific lens, but also engineering and infrastructure lens as well. And we'll cover both of those over the course of the presentation and discussion today. So to jump right in, this is a screenshot of what a phenotype can look like represented. This is not a computable phenotype in the sense that it can't be run, but it's easy to look at and say that someone has defined a set of codes, in this case, ICD-9 codes, some constraints around the codes, some additional criteria, and that represents a phenotype, a written definition of the logic that is going in this case to defining dementia. Now, there's been a lot of great work done around phenotyping over the past decade, and I think some of the most important and seminal work that emerged from the eMERGE network and the PhiKB database, or sorry, PhiKB site, where they provided a set of phenotypes being used for research and also made available publicly. And while some of these were in written form, such as a Word document, others were provided in forms like an algorithm, as well as code sets. Others were provided in a more computable form, a range of different phenotypes. And then as new actors came into play, there's been sort of the increasing focus around computable phenotypes from the ground up. So PhiKB and Project FEMA has put together what is a computable phenotype framework to be able to represent definitions. In this case, this is one around BPH, or benign prosthetic hypertrophy, and representing it in a computable form from the ground up. The Odyssey network has tools, in this case, something called Atlas, that provides phenotype authoring and creation capabilities, kind of similarly putting together criteria to represent. PopMedNet, which is used by Sentinel and PCORNet, in addition to other tools that those networks use, enables the defining of data elements that may be looked at for querying out certain types of information and putting in constraints. And there's many other tools that these networks and others use in order to define the phenotypes. I2B2, and one of the sort of original phenotype creation tools, allowed you to kind of pull together different logical elements and constraints around those and be able to run them against I2B2 formatted data sets. Regardless of which system was used to create or define the phenotype, if it was using a tool, it generally would be put into some form of a computable instantiation. So it might be some type of JSON code or XML structure or SQL format that enabled it to be run with the right machinery against a data set and that data model. And so the computable component means that you could share these definitions. You could send the code from one site to the next. And the very powerful capabilities around computable phenotypes are reflected in this ability to share. So while the publication can be moved and reviewed quickly, there's still some loss or potentially lossy aspects in someone converting that to their local analysis, where at least the phenotype portion, if built computably, could be delivered in a consistent way. So all of the above examples that I've described reflect research data models or research data initiatives. But I want to emphasize and really expand on the kind of two different notions of data models that I think are increasingly becoming interwoven as we think about the types of analytics that we'd like to do around safety and other types of clinical questions. So the research data models, as we've talked about now, are typically population level. They're focused on the sort of full numbers of people in a given population. They're really designed to support analytics. There's a handful of models. So there are, maybe 5 models or 6 models, and there may be some disagreements and competition around the models, but ultimately it's a relatively small focus number. And adoption varies nationally and internationally. That adoption is often driven by things like funding, by collaborations. They're dominated generally by large medical centers in terms of the kind of implementation. And in the United States, there's no mandate regarding research data models. So there's no one who comes in and says, you need to be using I2B2 to be a research university as of 2024. No one's saying you have to use OMOP if you want to get an NIH grant by 2023. These don't exist on the research side. On the transactional side, things are a bit different. Transactional data models are patient level. They're really designed to support clinical operations. There's truly hundreds of data models because there were many dozens of EHRs. And then even within a given EHR, if you were running Epic at one site, you might have a slightly different data model behind the scenes than Epic running at another site. And then of course, there were operational or transactional data models from HL7, version 2, version 3, FHIR, and so forth. The data within those would have a wide array of local code systems, often that were used in addition perhaps to standards. And because of these somewhat proprietary formats, it sort of limited the utility for running queries beyond a single site. So while within your organization, if you were a hospital running a Cerner and you had a particular query you would run to find patients with poorly controlled diabetes, it really was not very easy to just drop that query into 20 other sites and make it run, which is of course why a lot of the research data models evolved. But one of the big differences, another one of the big differences, I should say, and a particularly important one, is that in the US, new regulatory policy has emerged that has significant implications for transactional data models, and also, I believe, for research in health analytics. So this change from a regulatory perspective is something called the 21st Century Cures Act, which was signed in December 2016. It was signed under the Obama administration. And the final rule regarding its implementation was published May 1st, and it went into effect on June 30th. And the 21st Century Cures Act contains many regulations which are relevant and interesting and really would be the subject and have been the subject of many webinars. But I want to focus on a particular piece or pieces that I think are quite relevant to today's discussion. And that is something called US Core Data for Interoperability, or USCDI. So what the USCDI does or is it establishes a set of data classes and elements that all certified health IT software must be able to export by 2022 or 2023, depending on the type. It also specifies a terminology or terminologies for each data class in this list. And it specifies a process for updating these data classes and elements and terminologies based on stakeholder needs, but balancing it with the IT burden on software vendors who need to create software that conforms to these regulations. So on this page here, and sorry it's a bit small, but I'll be zooming in a moment, is the list of the USCDI version 1 classes and data elements. And they're already in the works of gathering feedback for version 2. But this is the initial set of classes and data elements. And I just wanted to highlight a few areas and terminology. So there's standards here. So problems should be represented in SNOMED as the standard terminology. Tests should be represented in LOINC. Medication should be represented in RX norm. And these might not sound like particularly radical departures in any way. These are probably what maybe a lot of people on the phone might suggest, but it's very, very important to note that this is a mandate from the government saying that if you are going to run a certified EHR, which you pretty much need to have your EHR certified for it to get brought into large systems or any size systems, you are going to need to be able to export those medications in RX norm or have those tests in LOINC and not just in the local code system that ran before, which is a really significant change. They also provide term standards around things that maybe are not as clear. So allergies, how do you represent it? And they say, well, medications by RX norm and reactions by SNOMED, that's how it should come out. And birth sex should be standardized using the HL7 value set for administrative gender and so forth. And so they lay this out. So whether agreed or not agreed, it tells us that in 2022, systems will be required to be able to export their data using these content data elements and data standards. They also say that clinical notes have to be able to be exported standardly as well. And they reference a number of codes from the LOINC document ontology, different types of, but most importantly is that these are very common and important notes. Discharge summaries, history and physical, imaging, laboratories, pathology notes, procedure notes, progress notes. This forms the core when people talk about 80% of clinical data is found in unstructured form. Probably 73% of that 80% are in these major notes. I mean, these major sources. They're very, very valuable sources, and they will be required export content under the USCDI Cures Act regulations. So one other thing about the Cures Act, in addition to the USCDI, relates to FHIR, which I'm sure people have heard of in some ways, but may or may not have gotten a very deep dive. We won't be doing a deep dive on that here, but I just want to comment on one aspect, which is USCDI is about content. It's about what is the semantic interoperability. But in terms of syntax, ONC and putting out the final rules said that when you exchange information using APIs that help data, it should be done using FHIR release 4, FHIR R4. And so that is what everyone should be working towards together. And so these two elements, the USCDI and FHIR R4, are kind of fused together through the FHIR US core profiles, which sort of Argonaut, if people have heard that framework. But basically, this defines a set of FHIR resources and elements in a way that satisfies the USCDI exchange requirements. And so before we get back to phenotyping in just a moment, I'll just show you a couple examples here. And again, sorry, this is very small, but this is really just making the point that all of these USCDI elements have been mapped over to the FHIR core. So there's a relationship between the two. And for example, if you're going to get labs via FHIR, you can count on there'll be a laboratory status and there'll be a LOINC code and there'll be a patient. And you may also get date and other information, but there are certain things that are required to be put out. And that's what the core and USCDI and the Cures Act regulations are all about. And they return data essentially, and this is just JSON not to read, but just to show it sort of returns in a standard structure. The big difference from FHIR 2 years ago or a year ago to FHIR 2 years from now is that the content is now of a required format. And here until now, FHIR could be sent to you, but you had no idea. Am I getting a local code system? Am I getting ICD-9? Am I getting ICD-10? Am I getting a medication using GCN sequence numbers? We're now seeing a standard pathway by which you'll know not only the format of what you're getting in FHIR, but the content structure. It's coming in RX norm, and it's going to be brought out in a way that you can rely on that's mandated. So the Cures Act mandated the support for both patient and population level data export. It didn't specify the format for population level export, but it mandated the adoption of something called the FHIR bulk data access, sometimes called bulk FHIR or flat FHIR group export functionality. And this basically means that they mandated a mechanism to be able to take hundreds or thousands of patients at a time out to export via FHIR rather than one patient at a time, which has sort of been the standard model. While this doesn't solve the population level data question, it does move us much closer to being able to think about FHIR and use for population level types of analyses. So that was a lot of overview, but I think to me, it's very important as we think about portability and scalability. And so I want to kind of, with that context, get back to the tale of phenotyping and talk about the question of what makes a phenotype portable. And I would posit that one is that it uses data types that can be found across systems. Two is it uses or includes codes that can be found across systems. And finally, it uses logic that can be applied across systems. So focusing on the first one and using data types, how do we know what data types can be found across systems? And so there's, of course, been a lot of work looking at data model harmonization, and the Bridge model and initiative around that, really tremendous work looking at all the different elements that might be included, and then the Common Data Model Harmonization Project as a collaboration of FDA and NLM and NCATS and others, looking at 4 of the major data models at the CoreNet model, at I2B2, at OMOP, the Sentinel model, and basically mapping these together such that they could look at what is the common target using the Bridge model, and ultimately also that has then been mapped to FHIR. So what we essentially now have are mappings that go from every standard data model, not everyone, but the 4 that were done here, CoreNet, OMOP, I2B2, and Sentinel, into the FHIR US core. We have established those bridges. The really hard work of doing that has been done by extremely dedicated individuals. And so when we think about kind of how do we do that first step, which is, can I use data that are data types that are available across different systems? But before we get into analyzing the data themselves, we can think about it in 2 different ways. One is that they're sort of the classics, which are typically found: conditions, medications, procedures, the presence of certain observations or labs and encounters. But what we're also seeing is that the adoption of USCDI and the FHIR core expands the potential to incorporate elements standardly, required elements that must be able to be exported, that include vital signs, and include laboratory results, and include clinical notes that have to be able to come out from these environments. Now, of course, they won't work across every data source. They won't work across claim sets that don't have this information. But if we think about the increasing number of sites and sources that will be able to export those data types, it opens up consideration to move beyond just the initial sort of core classic data types that are used before. But I think even trickier, probably for most, than picking a condition versus should I analyze something else, is trying to decide what codes can be used or should be used or can be found across systems. And so the question really stands tall: how do we know what codes are in what system? And I want to highlight some new cohort characterization tools that really expand our ability to understand the availability and the impact of code selection within phenotypes, because we really want to understand what codes are actually used when we generate a cohort and how that differs from site to site. And I'll borrow a little bit from Odyssey here because I'm most familiar with Odyssey. I'm certain that each model has different tools to address these kinds of similar questions. This is kind of the classic sort of original model for characterizing data in Odyssey, where and they're still very valuable tools, where you basically look at a data set or you look at a given generated cohort and just kind of count up, well, how frequently did I see a given code in that data set? And that provides some insight and information into maybe the codes that one should pick in doing a kind of phenotype and defining a code set. But some of the next generation cohort characterization tools, particularly the cohort diagnostics tool from Odyssey, really provides extensive insight into how codes are used and what codes may be missing. So here's an example of looking at diabetes. And what this cohort diagnostics tool is doing is it's looking at all of the codes that triggered a inclusion of someone into a cohort for diabetes. So for example, you can see diabetes without complication, type 2 diabetes, poor controlled diabetes, et cetera. And this is for type 2 diabetes, by the way. And it shows at some different sites at Columbia, at Claim Center, at Stanford, at the VA, different types of claim sets. What were the actual codes that led someone to being included in that data set so they could be compared? But you could also take a look and say, well, let me look at the code list that I had entered as my possible list of diabetes type 2 diagnoses here. And what are the elements, what numbers of people had this code at each site, which is similar to what we saw before, but also in a really clever way, looking at something called orphan codes, which are codes that are sort of similar semantically to the codes that you included in your code list, but that in fact did not make your code list. So it says, well, what about gestational diabetes? Or what about family history of diabetes? And it's able to do that because it's recognizing that the term diabetes appeared in many of your codes, but there are many other terms that you left out. So of course, family history of diabetes, we don't want here. That doesn't mean diabetes. And we're not interested in type 1 diabetes in this case. We're focused on type 2. And you also see, for example, phrases like diabetes insipidus, which certainly is not something we would want. But what this is able to do is surface codes that may have been left out and enables the creator of the phenotype to go back and look and say, oh yeah, actually that would be one to include. And what is the frequency of that code? How many people might I have missed, or how many potential opportunities might I have missed if I had not included that code as well? So these are extremely useful resources. Now, another example, just to provide, is one around obesity. And I think this is a neat one because you can see that when we're looking at electronic medical records or health records from healthcare systems like Columbia or Stanford or the VA, we have body weight and body mass index and so forth present in significant numbers. But of course, in our claims data sets, we're much more likely to bring someone in by an index concept that relates to a diagnosis, like diagnosis of obesity or an elevated BMI and so forth. And so this similarly provides us for what was the triggering index event for different patients coming into into the obesity cohort, and shows us what are the common codes found in claims, what are the orphan concepts that weren't there, and again, things that are interesting, and some of them might be quite useful. For example, someone who had a gastric bypass. Well, a gastric bypass may be significant enough for you to include as being an indicator of obesity. But something like obesity screening or something like the biopsy of a fat pad would not be something that would indicate. So once again, this type of work, which provides counts and related concepts, helps us, when we're looking across multiple data sets, have a better sense of what should be included in order to catch patients not only in this one data set, but across multiple sets. And we can see what types of structured codes, such as weight codes, are found as well, what LOINC codes can be used. So this cohort diagnostics tool has many, many very valuable aspects. And as we start seeing more required data, such as vital signs, blood pressure, heart rate, et cetera, come through, will become even more valuable for looking at those structured elements. So the last piece around making a phenotype portable is around using logic that can be applied across systems. So there are standards that we've just talked about for what kind of data elements should be present. And there are standards now for what types of terminologies should be used to represent these data elements. That's a huge step forward. However, unlike those pieces, there's not a defining set of logical querying capabilities that's required. So to represent temporal logic or logic relative to an index event, or how many occurrences occurred, or how things are grouped, there's no federal body requiring that systems be able to query things in certain ways. But I think that hope can be found in looking at some of the CMS, electronic clinical quality measures, or ECQMs, that are being transitioned to broad interoperability standards. So a brief word about a CQM. So a clinical quality measure, they're measures that are required reporting for all providers and hospitals that participate in Medicare, Medicaid, particular programs around interoperability. And the performance on those measures, clinical quality measures, is tied to reimbursement. Each CQM is essentially defined by a numerator and denominator cohort. And as such, an ECQM is a computable phenotype that represents those cohorts to ensure consistency in the reporting process for Medicare and Medicaid. They include data model and code sets and logic wrapped together. So these ECQMs, and this is sort of the overall structure. Again, there's a data model, there's expression logic, and there's sort of a structure to how they're formatted, but we're primarily interested in this expression logic aspect. It's represented using something called CQL, or clinical quality language. And even though the ECQM is sort of transforming from an older approach to a newer Firebase model, they still use this logic, this CQL logic, as the standard. That CQL, or clinical quality language, is essentially a human readable but also machine interpretable code that lets you sort of specify things like an encounter in an ambulatory visit, or a condition that's defined in certain ways that you call acute pharyngitis in this case, with certain onset times. It leverages very heavily not only embedded concept codes, which is something that generally our concept sets do when we build them for Odyssey or I2B2. We're kind of putting all of that concept logic into our definition, but they rely very heavily on the external National Library of Medicine VSAC, or Value Set Authority Center. And they put value sets in a format that references those VSAC codes, which enables those codes to be shared very easily, and they're not embedded or don't have to be embedded. They can be. There's extensive date manipulation logic, and each of these CQLs gets compiled into a query execution mechanism, such as FHIR. So CQL basically is the logic which then gets crunched into the query mechanism. And just to get a look at what CQL looks like, it has, as I mentioned, this sort of set of value sets. Sorry, this one's a bit small. This is around atrial flutter and warfarin exposure, and it has basically a number up here which references the Value Set Authority Center and goes and retrieves all of these codes related to atrial flutter, and it pulls them in at runtime. And then it says, well, here's the time period we'd like to look at, and I'd like to assign atrial flutter, a certain diagnosis, and warfarin to medication exposures. And basically, as you can imagine, in creating a phenotype for any system, you're kind of talking about encounters and conditions and medications, and you're just grouping them logically in a way that enables you to say, I want to look for patients who first had an A flutter and then they received, in this case, warfarin, and their warfarin levels or INRs were certain values. So it's very similar to how you create another phenotype. What's actually quite interesting is that a number of the data models have shown integration with the Value Set Authority Center. And you can see here that there's a VSAC to OMOP connection. The eMERGE network has done a lot of work in terms of being a steward on VSAC. There's APIs to pull data from VSAC. But overall, there's a pretty thin showing from the major research networks, be it Odyssey, Sentinel, ACT, at least visibly as stewards of data code sets on VSAC. And it's something that enables us to share code sets across platforms in a way that's a common open standard and is heavily used. So even though we have some work that enables inbound retrieval, there's opportunities for some of the research platforms to push their data out to make it more shareable across platforms. Now, we talked about logic and how CQL provides some representation of maybe a generalized logic that we're seeing used for a common need, which is quality reporting. But we've also seen that clinical notes and unstructured data are going to be part of reporting going forward. So how do we apply logic beyond structured data? Again, the USCDCI mandating 8 common and valuable clinical data types. So how can we call them out while conforming to the broader phenotype structure? And there's a number of valid approaches that can be used to apply unstructured data to create phenotypes that, while complex in their notion, are in fact portable. One approach that's sometimes used is using NLP to pre-populate structured fields so that, for example, in the OMOP note table, you can pull data out, you can process it, and then you can push those into structured tables. So you're basically creating a structured data element in sort of a pre-populating way. And that is a useful and common approach for NLP so that it can be incorporating structured text or unstructured text without having to do it at the time of actually running a phenotype. Another approach is using NLP in real-time queries that augment structured feature definitions. So you can use things like stroke is defined as a given structured code set, or the presence of certain terms like occlusion or ischemia on a head CT. And that's basically making that concept broader. Another approach is using NLP in real time to create unstructured features that are sort of special and dedicated. So something like a greater than a 2 centimeter lung mass is not something that has a simple SNOMED code, not sort of simple representation, but it's a constellation of findings. However, with unstructured data, you can find these and you can define concepts or features using various tools and algorithms that will go and extract those elements. In all of these cases, you must be able to integrate the natural language processing derived features back into the logical pipeline for structured data. So however you're confluencing these, they need to be done. At Georgia Tech, we have an open source platform, Clarity NLP, that hybridizes structured features derived via CQL and unstructured features derived via NLPQL, which is sort of an unstructured query model. But however this is approached, there's a very, very significant opportunity now to begin incorporating more unstructured data because it's required export elements from the USCDI. Now, how do you assess the portability? If you feel that you've looked at the code and data types and the code sets and the logic, well, in the absence of markedly different baseline populations, a portable phenotype should create comparable patient populations across sites. That is, a group of patients who have a similar clinical condition should look more or less the same. And again, here, I'm going to look to and highlight the work of the Odyssey cohort diagnostics group, which has done some really innovative work in this area. And again, there may be comparable work that's gone on across sites across platforms. But I think it's a really, really exciting path to how we can look at whether a cohort is in fact consistent across sites. And so what you can see here, first of all, is that I'm looking at a number of different conditions going down rows: diabetes, hypertension, kidney disease, heart disease, etc. And it's showing me what's the relative number of patients who have these conditions at Columbia and in claims databases in Stanford and the VA. And what you can see, even just glancing down, is that there seems to be some general consistency. In other words, hypertension patients are more than the diabetes patients by this certain amount. We have smaller numbers of patients with COPD. Things you can sort of get a glance and say, are there any that seem particularly off? Well, certainly one that we see off is pregnant women as a cohort in the VA. And no surprises there, of course, for obvious reasons. But it actually is reassuring to see that, yeah, those numbers look different at the VA than they look at other sites. So we can see what are some differences in the frequency or prevalence of these phenotypes across different sites, and are they consistent? But we can also look, for example, at the distribution across age and gender. So when I look at asthma, and I put this in quotes because it's a phenotype, it's not a code for asthma, but it's a definition, it's a phenotype. I see that, yes, okay, young people do in fact have asthma with greater frequency, and I see that males have it with a greater frequency across all of these different sites that I have here, and that goes down over time. I noticed that heart disease has a similar balance and increase over time that's actually pretty consistent. And while some centers may have 100-year-old patients or 110-year-old patients, they're pretty rare. But when I look at across the core, I see here that there's consistency in that. And that gives me some reassurance that my definition of heart disease or my definition of asthma, whether it's right or wrong, is probably generating a similar group of people across these different sites, which goes a long way in commenting on portability. Something else I can do with cohort diagnostics is looking at comorbidities. So here's comorbidities of influenza patients, and I can see what is the rate of, for example, respiratory disease, hyperlipidemia, hypertension, rheumatoid arthritis, etc. This is a rheumatoid arthritis population, so there's higher levels there. But it basically lets me look at frequency and say, does this look consistent from my claim set and this claim set and this other EHR set? Again, giving me some insight into how consistent is this population. There's some similar things you can do looking at medications, and are we seeing condition frequencies or medication frequencies that are consistent? And there's some neat machine learning approaches that are quite exciting as well for those that are interested. Take a look at the Phenotype Evaluator tool by Joel Swerdell, which looks at some of this from a machine learning perspective. But I think just at the baseline, the ability to compare the prevalence of medications, conditions, spread of demographics from site to site for given phenotype definitions is a very, very strong move towards improving, ensuring, or at minimum assessing the portability of phenotypes. So to summarize on portability, how do we make phenotypes portable? Well, we should be using data types that can be found across systems. So we can find those by looking at models and emerging mandated standards. We can leverage required data types, such as those we're seeing in USCDI. We can include codes that are found across systems by looking at dataset characterization tools and cohort characterization tools, but also by looking at or publishing concept sets that we create in code sets on VSAC, on the NLM Value Set Authority Center. We can use logic applied across systems by avoiding sort of the exotic logical operators and looking at the more traditional ones. CQL, which is used at least for the CMS measures that we know have to be implemented, can be a guide and actually has a pretty robust set of logical operators. I've talked a lot about portability. Scalability is in some ways a much shorter story because we've covered all of that around portability. So scalability, what makes a phenotype scalable is that it meets all the criteria for portability and there exists actual machinery to run the phenotype at a large number of sites. Now, these are maps of, at least from what could be readily found around the networks of some of the different data model, or I should say consortia that are around different data models, Odyssey and ACT and PCORNet, and with Sentinel. Of course, Sentinel has 17 different groups, which can expand many. So I couldn't find the exact same map, but you can see that there's a lot of different sites. There's distribution. There's also gaps. That's what we would expect to see, particularly with a lot of focus on larger centers. In contrast, this is a look at the availability of sort of a FHIR connections through something called OneUp Health, where you can see that there's FHIR. I think they've got something like 3,000 or 4,000 sites that are connected on OneUp Health. And you can see the breadth of it, and it's very different because this is mandated. This is because health systems are required to enable the sharing with patients. And this isn't about sharing of research data. This is about sharing of individual patient level data to patients. It's a mandate, it's required. So of course it's spread much more quickly and has a very broad set of places that are using it. This is a slide from the work of the Da Vinci Project, and really tremendous work that Viet Nguyen and others have done with the Da Vinci Project around connecting payers and health systems for speeding processes such as prior authorization of procedures and medications. And they're using the tools that we've discussed, CQL and FHIR, to move these data around. And you can see who are the players, who are the founding members of these groups. Well, Anthem, Blue Cross Blue Shield, CMS, CVS, Humana, Cigna, United. I mean, these are the founding members, payers, in addition to, of course, major vendors and providers and EHRs. And what this tells you, or at least tells me, is when I see a lot of payers involved in doing something at scale, it's now multiple years into the project, and there's been a federal mandate around the use of certain technologies related to this. I have a really good feeling that this will drive increased and continued adoption of the technologies that they're promoting, because that's how organizations will be paid, and that's how data will move through the system. And so when it comes to improving phenotype scalability, I believe it's not about the phenotype design, which is portability, and we've talked about, but we really need to make our phenotypes runnable in more places. So yes, as a given data network, we have to continue to expand individual platform adoption. And that may be to simplify how people convert or do an ETL into your model, how the code is deployed and the simplicity of that, how they add value in other dimensions, participating organizations, publishing about the work that's done. But I also think we must take advantage of the transitions that are already underway in health systems related to interoperability. So in a sense, to both keep the baby and the bathwater is that when building phenotypes for your network, when creating phenotypes, whether I'm doing it for a research project in Odyssey, or we're doing work collaboratively around with the CTSAs and ACT network, we should begin looking at how do we have a parallel pipeline to export our logic, or the core of our logic, using CQL and putting our concept sets out on the Value Set Authority Center, whether we use those code sets or we simply publish our code sets that we've used to enable more to take advantage of them. And then as the FHIR mandates come into place and CQL becomes a standard for health system payer interactions and reporting on quality, we'll have phenotypes that can piggyback on these technologies, which we know are coming and required. And so thus, as a platform, we can model, or we can leverage a far broader range of sites as data partners. So perhaps there's an extended tier of data network collaborators in addition to the native platform adopters. So the Odyssey community will still have its community, and the Sentinel community, and ITV2 and ACT, and these are all overlapping groups, but also this extended tier of health systems around the country using these core technologies that can be leveraged collaboratively to bring very valuable data to the fore without the lift and cost and expense for them beyond what they're already doing as part of their mandated reporting and interactions with payers. So a couple caveats on this. Number one is that the regulations I've described are not internationally adopted. The ONC refers it's US-centric, and that, of course, is a notable consideration and limitation, but still one that bears mentioning. The performance of patient-level technologies, so things like FHIR and FHIR data models for population-level analytics, will take time to catch up. I think what we can do across the board on phenotyping and analyses using the sort of native population data models is certainly much more performant than where we are now with the patient-level technologies, but I think those will move forward quickly. And that, of course, culling data from a broader range of sites, smaller hospitals, smaller clinics and health systems, as well as larger ones that have not been affiliated, will introduce even more variability in the populations and variability in data quality that will need to be addressed. With all this being said, I think there's great opportunities for both the portability and scalability of phenotyping, and I'm very grateful for your time today and happy to answer any questions. Thank you very much.
John, thank you. That was really terrific. And I know stimulated a lot of ideas. We have a question from one of our attendees, and I'll read it. I think you can see it, but I'll read it so that others who are with us know the question before you answer. The question is, how do you bridge portability from the operational perspective? That is, the ability to have codes to create phenotypes to the construct validity. We know that the same phenotype doesn't have the same performance when applied across different databases, positive predictive value, negative predictive value, and the like. So while we have the data elements to code in a similar way across databases, there are nuances in interpretation. We can make something runnable, but it may not always be a solution in itself. Can you comment on that?
Absolutely. So this is it's an absolutely fantastic point, which is that even with the portability and even with some of the sort of characterization, are we seeing some consistency perhaps in the demographics or general comorbidities? We don't really have a firm knowledge that we're getting the same consistent cohort that we're looking for. And so the notion of validation is very critical. And this individual mentioned this in in the second part of their question, but I think it applies here as well, which is to say having standardized approaches for evaluating phenotype performance within a given site is critical, which is, for example, that may be a set of standard questions that should be evaluated for looking at a case report and saying, everyone who runs this should look at 100 patients, assess for these case or no case questions. It could be something along the lines of here's some errors that we're seeing at one site, and we're going to share those and see if other sites are seeing similar errors. But that's a great point. Validation does have to be done to be able to make anything beyond kind of an inference that, yes, these are in fact portable. You actually do need to do the validation. Validations are typically done within a given site because they're able to review the full chart and look at some of the aspects of manual code review. So that's a really important point. And I didn't talk about validation, but it should be considered part and parcel with these objectives.
Thanks, John. Actually, the second question is also about validation. So you began to answer it, but let me just read it as so that others can see it or others can hear it. Please speak to validation efforts regarding these phenotypes and how validation is performed when there's a greater emphasis on the big tent concepts of portability and connection to VSAC, which will likely increase sensitivity but decrease positive predictive value. For FDA to feel confident in secondary use observational data, they generally need validation, particularly when they are a largely mapped concept from a diverse set of raw codes. Are there gold standard validation studies you are aware of? And you referenced that being usually a local case, but can you speak a little bit to those gold standards that might exist?
It's an interesting question because, well, I don't necessarily equate sort of the Big Ten of concepts with it inherently or necessarily having to decrease the performance in terms of specificity. I think where we do get into trouble would be if the way that the concepts are used are quite different from site to site, and they might be. And I think that to me is what really stands out with this question, is that, you know, a given site might use a concept and in a way that's different, and thus you're picking up patients that should not be picked up. I think the circumstances that may be more common, which is that one site kind of people code a thing a certain way and another site people code a thing another way, is probably okay because you sort of have like a very low or zero count for, you know, code one at this place, and you have a very high count for code one at the other, and vice versa. And thus you're just kind of picking people up, but there's not as much in the way of false positives. But I think where you do get different approaches to coding from one site to another, and where, you know, diabetes type 2, you know, at this site they're using, you know, rule out hypothyroidism, and they're entering a hypothyroid diagnosis, and another site doesn't, then you'll certainly run into those problems if you're including those. So I think it's an important consideration, but I just wanted to kind of make the point that I think the Big Tent may increase or may decrease positive predictive value, but doesn't necessarily have to. In terms of the validation, you know, I think you know, the diversity of raw code sets, one of the things that I showed on the characterization was what were the concepts that introduced a positive index event, and then what are some maybe orphan concepts or concepts that were left out that would have increased the numbers at a given site. And so I think perhaps if we got a little bit smarter or began working further down that pathway of understanding how do we use that information about here's how people were getting picked up from site to site and the variability, as well as here's codes that were missing and would at one site have produced a bunch more patients, and yet at another site wouldn't really have added that many patients at all. I think those kind of elements can help us understand better the kind of ways to target validation and creation. More generally, though, it does come back to the same question. So in terms of gold standard validation studies, I'm not sure if the question is about a method for doing manual validation in a best practices kind of way, or if is there a method for sort of doing large scale validation across a lot of sites. So if you want to clarify that, I can try to answer it.
I'll guess it's probably the latter, given the Sentinel perspective here, that is doing it more at scale. But that would be my guess.
Yeah, so the certainly so the answer to a gold standard approach that is going to be right. I can say work that's gone in that direction. I mentioned the phenotype evaluator, phi evaluator, that Joel Swerdell et al. Did, is an effort in that direction. I think what we don't have yet that I've seen is, okay, here's a study which took a broad scale approach and then validated it against manual approaches at 20 different sites. And we saw consistent findings that this automated approach generated similar performance data as these individually local manual validation processes. I have not seen that study, but I've got 3 kids who just started school this morning and a lot of things going on. So it's very possible.
Might have been published today, and you just
Yeah, it might.
John, this is really terrific. I know we're about out of time. I just wanted to, my question for you was less of a question and more of a comment underscoring a point that you made, and that is really the importance of reimbursement, really bringing along these the USCDI, all of the requirements, the mandates that exist in 20th century cures. So as you pointed out, as soon as payers require not only that those be used, but that's how you get paid, we will suddenly begin to see much more useful data being captured, I think, at the source, right?
I absolutely. I think we're not for electronic billing systems. Probably none of us would be doing this work now. And I think that we're going to see the next wave of exactly that. That it's going to open up a really huge range of possibilities for electronic for observational data research that goes far beyond the specific intention of billing, but is a benefit that we all can enjoy from that.
Yeah, absolutely. Well, John, I want to thank you for what really was both a detailed and really clear presentation, a lot of content, and really addressed the concepts of scalability and portability in just a very clear way. So thank you for doing that. It was great to have you join us today. I really do appreciate it. As a reminder, this session has been recorded and will be made available through the Sentinel webpage. You can find details and registration links for future Innovation Center webinars on the website, which is sentinelinitiative.org. This does conclude our session, and we really hope to see you again next time. Again, thank you, John.
Thanks very much.